We're going to transition to the team in Oregon. Kasuma Matamala is going to start us off along with Sarah Boudreau and Michael Baker. So I'll turn it over to them next.
Great, thank you. We're glad to be here today to talk about one case study describing a successful cross-jurisdictional staffing partnership across 3 counties in Oregon. I'm Sarah Boudreau. Next slide, please. In 2015, the Oregon legislature enacted into law a new framework for the governmental public health system in Oregon, closely aligned with the National Foundational Public Health Services model. We call it public health modernization. With this law, the legislature made a commitment to increase funding over time to implement a modern public health system, and the public health system in turn made a commitment to continue to look for effective ways to improve public health service delivery. So with a small investment in 2017 of $5 million, Oregon Health Authority and our local public health authorities agreed to fund regional partnership projects focused on communicable disease control, eliminating related disparities, and building infrastructure for cross-jurisdictional sharing. Oregon Health Authority opened a competitive grant process and awarded 8 regional partnerships spanning most areas of our state. And even as we've increased our investments from the legislature in recent years, we've continued to invest in this regional partnership model, which we'll be talking more about today. One thing I really do want to emphasize, though, is that these regional partnerships are not about regionalizing or consolidating public health departments. It's really not about saving money or doing more with less. It is about finding effective ways to support a public health workforce that can serve communities in every single corner of our state. Next slide, please. So quickly, this slide shows the 8 partnerships that were originally funded in 2017. Next slide. And this slide shows the location of the Central Oregon TriCounty partnership, which will be the focus for the remainder of our presentation. So Central Oregon is in Oregon's high desert, just to the east of the Cascade Mountain Range. It's comprised of Crook, Deschutes, and Jefferson counties, and the lands of the Confederated Tribes of Warm Springs. Central Oregon is the last population center before moving into the frontier counties in Eastern Oregon. Next slide, please. So these 3 counties, they share one hospital health system, they share one FQHC system, they share one Medicaid coordinated care provider. The population really moves seamlessly among the 3 counties. Deschutes County is the largest county population-wise, and therefore they have access to a more robust public health workforce than Crook and Jefferson counties. Central Oregon is also known to be leaders among LPHAs, and I'm very glad you'll have a chance to hear from one of these leaders, Dr. Michael Baker, in just a couple minutes. So even before 2017 and this funding opportunity, they had a history of working together to meet the needs of their shared community. In fact, they'd already mapped out 10 bodies of work that they felt could be done across their counties and the positions needed to support this work. So when this funding opportunity became available, they were ready to go. They created the Central Oregon Outbreak Response Surveillance, Prevention, Surveillance, and Response Team. From looking at their data, they knew that some of their most vulnerable populations were older adults living in long-term care facilities and children attending child cares with high vaccine exemption rates. So this is where they built their project. Their goals were to improve outbreak coordination, surveillance practices, and risk communication with healthcare and other partners. They did this primarily by employing 2 new regional positions, a regional infection prevention specialist and a regional epidemiologist. So all of this is why Central Oregon was selected in 2019 as a success story case study prior to the beginning of the COVID-19 pandemic. Next slide.
Thank you, Sarah. So I'm going to share some findings from a case study because we really wanted to dive a little bit deeper and understand some of the areas that were that Central Oregon was working on, and to see if it could be replicable in other parts of the state. So this case study was started in January 2020, right before the pandemic, and ended in June of 21. The methods included some key informant interviews and some data and document review. And given our time limitations today, I'm really going to just focus on what we were trying to learn before COVID and how that got impacted and how that evolved later. As Sarah noted, you can see the Tri-County partnership goal noted here. And as she mentioned, there's a Tri-County focused epidemiologist, as well as the public health nurse, really focused on infection prevention during the region. And we really wanted to get a sense of what was, were they able to, how were we able to, in this case study, to assess a more effective public health presence? And unfortunately, it was just those first 2 months before COVID started, but the pre-COVID review really looking at improved responsiveness for reportable diseases, expanded reach to the target population, quality of service, and quality enhancement to data systems. And then how did that work shift with COVID, and what were some of the implications to their workforce? So on this slide, you can see in terms of improved responsiveness for reportable diseases, you can see 2 time points, 2016 and 2019 for the 3 counties in the region. And these metrics are around: one, it's proportion of cases with the first interview case attempt in 4 days, and the other one is case investigations completed in required time frame. As you can see, most of these cases improved in their responsiveness across all 3 counties, and these metrics come from the Oregon Health Authority conducts a comprehensive review of each public health authority, local public health authority in the state. And so 2017 was the time in which these regional positions came into play. They also expanded their reach to target populations, as Sarah indicated, with a focus on long-term care facilities as well as other areas, and really a specific outreach with the Confederated Tribes of Warm Springs, both in vaccination events for influenza and sharing cases and fostering relationships and preparedness drills prior to COVID. In terms of improved quality of service or program, they were providing weekly Tri-County surveillance reports during flu season, a Tri-County flu website, quarterly communicable disease reports, and just having the epidemiologist share local data with the nurse to include in her training content as well. In terms of quality enhancement to data systems, they established an MOU for their Essence data, or their surveillance system for early notification of community-based epidemics, as well as our Oregon Orpheus data, which is our Oregon electronic disease surveillance system, and being able to participate in trainings. There was weekly Tri-County surveillance data check-ins as well. And as you can see in the chart below, from 2016 to 2019, this is the proportion of complete risk factor information per county, and that also tended to increase with some time. So what were some of the implications during COVID? Well, each of these 3 county positions really helped build solid relationships in the region before COVID, and having that staff with strong training and relationships and generally how to navigate the system was really instrumental in their early days of their response. For example, the long-term care facilities actually reached out to the infection prevention nurse to help assist them in the early days of the pandemic and meet their PPE needs early on. And we know that only 5% of state outbreaks in long-term care facilities occurred in Central Oregon from the start of the pandemic to November of 2020. So the 2 positions remained the same, but became really topically focused on COVID. And they were thankful to have people coming to the health department, but they also recognize that people just don't know how small local health departments are in terms of their staffing. And they really need to prioritize their staffing capacity. Here's a quote here from a former Deschutes County Health Department manager, that they were thankful to have this regional model in place, and they would be in a world of hurt if they didn't have these 2 positions. That communicable disease was really thrust into the spotlight, and they were better prepared to be in that spotlight because of some of that modernization funding. They also established a joint COVID information center pretty early in March of 2020, releasing consistent information since there's similar media markets in that region, and just learning what they needed to know and communicate it similarly across county lines. Because each county has its own communications and epi reports, they really had to be consistent in that information and the same level of detail that was being provided. And those reports were coordinated with each leadership in each of the counties. And as we all know, there was just a need for accelerated rapid reporting. But because of the surges, it was really hard to see the benefits of some of the earlier work that they were doing pre-pandemic, and that there were different phases that were manageable at the beginning, but having 3 counties with different needs really fell on existing staff. And it became difficult to maintain workforce capacity, even in a region that was pretty well set up for case investigation. And as they lose people, you lose institutional knowledge. So the 5 individuals that I had interviewed at the start of the case study, the health department directors and the regional staff, only 4 of them were remaining. That includes Dr. Baker, who will soon be speaking, who is our health department administrator for Jefferson County. These staff left either due to new jobs, retirement, or just a leave of absence. So for that regional epidemiologist model, we asked what would be needed to keep it going, what would be feasible. So she noted that it would be feasible in normal times in less populated areas, but due to the repeated surges, it just became too overwhelming to serve multiple counties experiencing crises simultaneously. So in order for it to be sustainable, they just really need greater mentorship since they're working solo, additional administrative and analyst support, a peer structured community. There was one that was established prior to COVID, but was just not meeting because of limited capacity. And as we know from other national public health workforce reports, just the need for a greater compensation, competitive compensation package, and sheer numbers of workforce, and not just one regional epi on communicable disease, but a variety of topics as well as multiple tiered epi capacity. And that state health departments can take a leadership role in supporting the regional workforce in these areas. So I'm going to turn it over to Dr. Baker right now to share his reflections as well.
Yeah, thank you. And I know we're really tight on time here, but we have some staff that serve in the military, and they're very fond of the saying bottom line up front. And I'm going to do that here. Bottom line up front, this program was incredibly successful for us here in Jefferson County. Jefferson County is really a small rural public health department. We've got 14 total full-time employees here. And the majority of those services are tied to some kind of direct for fee service. So there's very little flexibility with funding, very little staffing capacity to upscale when we need to. This program here allowed us to do that. Additionally, it allowed us to now have subject matter experts like a PhD epidemiologist, individuals that were with advanced nursing skill sets that we just didn't have here in a small rural community. In fact, we're still trying to recruit for a nurse that we've been recruiting for months now. We've had over 1,000 hits on the job site looking for it, but not a single applicant. Programs like this really helped us and continue to help us build our staffing capacity here locally. As Sarah mentioned, Central Oregon is really a tight meshed community. With in fact, really only politicians and map makers really distinguish between each county here in Central Oregon. We've got several communities that overlap the county boundaries. And so programs like this allow not just Jefferson County Public Health to provide services, but also for our partners Crook and Deschutes County to support with those services as well. Additionally, an extra benefit was with Deschutes County being the larger urban center in Central Oregon, we were now able to tap into nonprofit community-based organizations and other support mechanisms that weren't aware of the need of their services here. We were able to expand those services here in Jefferson County. Next slide, please. So the best way the road to success is paved with success is what we like to say. So this model proved successful. There's no question about it. We were able to expand services. We were able to get services to our community when needed. We were able to target highly vulnerable populations from a public health standpoint that we didn't have the bandwidth or capacity to do before. So now we're expanding those services. We're continuing the epidemiology work. We're continuing the long-term care facility. But now we're also expanding that role to include other congregate setting sites like our county jail, adult foster care homes and other congregate settings that we just didn't have the ability to connect with before. But now we see, based on the COVID response, how vulnerable these populations really are. And very exciting here is the expansion of what we're calling the Environmental Hazards Preparedness Coordinator, really looking at the impact that serious weather conditions have on our community: fire, floods, smoke, even serious winters. In a community that is still debating the conversation about climate change, the ability to partner with our neighboring county to be the lead in that really takes kind of a lot of the stressor off of us here, but also allows us to have the benefit of that partnership in place and the benefit of having that work done and kind of bypassing all the political considerations that go along with a position like that. So we're really excited about continuing the work. We're very thankful for the partnerships that we do have with this work, but continuing with our neighbor counties. Thank you.
Thank you, Michael and Sarah and Kasuma. It's actually a really important point that you've made, that recruiting into the workforce isn't as simple as posting jobs. And so if we can come up with solutions that facilitate someone meeting needs across communities, it could be a meaningful solution for other states and localities as well. So it's great to see some examples